Hello, this is John Canalopoulos from our center here in Athens, Greece, the LaserVision Optometry Surgery Center and Clinical Professor of Ophthalmology at NYU Grossman Med School in New York City, New York. We're going to see a 61-year-old physician who had a trifocal lens placed on her right eye in thinking that that eye was her dominant eye, and actually made this presentation in Rio de Janeiro just last week. So we can see here a perfect surgery. Unfortunately, her uncorrected visual acuity is just 20/25 minus, and this is her contrassensitivity. The right eye that was operated is the rhomboid, and still is subpar in most spatial frequencies, especially in mesopic and scotopic conditions. These are the wavefront maps of that right eye. The best I can say is terrible. This is the left eye with the cataract, and the wavefront is probably better here. So we discussed with our patient. This is the IOL master showing the surfake in the right eye, the significant cataract in the left eye. We opted that her dominant eye was her left eye, so we went in and with a heavy heart, and I always tell these patients that I deal with them as if they were my own patients, and I've had trifocal lenses that I had to explant. So we're calculating here the lens with a goal to be half a diopter with the rule astigmatic post-surgery. So we're going in, although the procedure was done with a femto, I'm going in at the 135-degree incision, which is my known incision, and I'm very familiar with the astigmatism that I produce. We're playing the video times 4 speed. I'm going in with viscode, and the trickiest thing here, and we're 2 months out, two and a half months out after procedure, is to find the edge of the anterior capsule. I remind you, this is a femto case, so I'm very concerned that the edge may tear. We know that the manual edges are more resilient to stretching. I'm going all the way around to get viscode around the lens, and the key thing is behind the lens. As you can see here, we're seeing a wave of viscoelastic, and then I'm using my Sinskey hook to pull the 2 haptics out of the capsule bag. And fortunately, this is going very well. Sometimes at 2.5 months, especially in our patients here in Greece, this is very difficult. And now all haptics are released, and I will bisect the lens. I'm adding in more viscoelastic. I'm grabbing the lens and I'm bisecting the lens with scissors in half, and we will pull each half out through our 2.75 millimeter incision, which is my go-to incision for my axial toric IOL, which I already, as we noted previously, have calculated to achieve a half diopter with the rule. This is the non-dominant eye. According to our assessment, I'm filling in the capsule bag. So we opted to go here with a minus 0.75 spherical target. This is the plus 23 diopter and a half of astigmatism. Hydrate the lens, fold the lens, and with the D cartridge go in. And this is our go-to technique. And I noted at the meeting in Rio de Janeiro, which was probably one of the best I've been, the Brazilian Association for Cataract Refractive Surgeons, that blended vision in our hands, aiming to a minus 0.2 in the dominant eye, and here, very important to remove the viscoelastic from under the lens, very careful not to grab the capsule, and this helps a lot with effective lens position, because if there's a pocket of viscoelastic behind the lens, that may change that position, and all the calculations, meticulous removal of viscoelastic, and then go in and place our lens at the markings. We mark the 6 o'clock on the slit lamp and use it as a plane. This is now the other eye, the dominant eye. Our goal here is a minus 0.2, again with a target of plus half a diopter with the rule of astigmatism. So if the patient is slight against the rule of astigmatism, we'll still put a toric lens. My incision always at the 135 mark. My paracentesis is just 1 millimeter. This is easier for me. This is a regular cataract procedure. I'm using methylcellulose on the surface, so we don't have to irrigate all the time, and we're doing a manual continuous curvilinear capsulorhexis courtesy of Thomas Neuham of Munich, Germany. I can still remember the first day I saw him do this as a resident at the State University of New York, Stony Brook Nassau County Medical Center. Obviously, free up the lens with hydro dissection and go in. We're seeing that although young in age, this lady has significant cataract. And from the lens power, we realized that she's an emmetrope, slight hyperope. Her work, dermatology work, is mainly with lasers, near vision. Somewhere intermediate and near, we discussed that she will have to wear some loops or some extra correction if she needs some very, very fine work up close. But I think that's all she will need at this point. Very meticulous in removing viscoelastic, going with my split through the prosthesis to remove the viscoelastic and, of course, the residual cortical material. This is a young patient, and all our calculations do rely on everything here be done by the book. And it is. I'm going to go in carefully and remove this last tag of viscoelastic, polish the posterior capsule, take out some tiny little fibers that are still there, and then go in with methylcellulose. Despite this done manually, the capture X is pretty decent. And again, this is the dominant eye. We're targeting a minus 0.2 in sphere and half a diopter with irregular astigmatism. So this is an astigmatic lens. Same thing, pretty much standard lens in the bag. Use irrigation aspiration to remove viscoelastic from underneath the bag. Very careful here not to tag the posterior capsule. And again, I noted previously why this is important for effective lens position. We're very happy that the patient achieved better than 20/20 at distance with both eyes. So she was 20/16 at distance and a J3 plus at near, J3, J2. This is a week after, but the key thing here is the contrastivity on your bottom right is excellent. It's better than normal. And this is the goal of blended vision and our target for surgery. This is John Galapos. Thanks so much for your attention.